call to order this, initial meeting of the Health Benefits and Qualifications Committee. So to start off, I want to remind everybody to please, state your name before you start talking, at least the first time, so that we can recognize your voice. Though a lot of people have been on this committee for several years now, we probably do recognize their voice. But let's start off by having introductions, a roll call. Marcin.
Okay, Graham Blader.
Here.
Tito Doolittle.
Here.
Yep. Mark Schaefer. Matthew Brockman.
Here.
Thank you. Manisa Tutani. Julian Cohen.
I'm on.
Ellen Skinner. And Mr. Paul Lombardo.
And I'm here, Marcin.
Thank you.
Okay, well, thank you. Can we also have everybody on the HCT staff introduce themselves one by one?
Good afternoon, James Michelle, Access Health Connecticut.
Hey, James. Hi.
Hello, happy New Year to all.
Sorry, James. Good afternoon, Susan Rich-By, Director of Legal and Governmental Affairs at Access Health Connecticut.
Hi, everyone. Glenn Jurgen, Director of Human Resources, Access Health Connecticut. Sorry if I cut you off, Daryl.
Sorry, Daryl Jones, Director of Finance, Access Health.
Gina Walsh, Director of Operations, Access Health.
Charmaine Lawson, Plan Management.
Kelly Cody, Plan Management.
Jackie Olgen, Plan Management.
Marcel Lachowski, Governance Specialist.
Anyone else? Okay, thank you. Let's next have Susan give us a little overview of the purpose of this advisory committee.
Thank you, Grant, and welcome to everybody for our new season for the committee. First, I'd like to just start with touching on the purpose of the committee, and just a reminder for everybody, as Grant mentioned, most of the people on the committee have been here for quite a while, but the Health Plan Benefits and Qualifications Advisory Committee makes recommendations to the Board of Access Health for the qualified health plan certification requirements, including the annual standard plan designs. The ACA requires the exchange to establish these requirements for certification, recertification, and also decertification of qualified health plans. So we will review the full list of the various certification requirements that the committee considers as part of the presentation today, and then get to work on the standard plan designs for plan year 2024. And I'd just like to take a moment to mention that there are some changes to the committee's membership at this point for this year, as two of our very valued members have retired from their professional positions and also are stepping down from the committee. Neil Kelsey, who's been with Connecticut, and Jill Zorn has also retired and is stepping down from the committee. So we just want to take a moment to express our extreme gratification for all of their contributions over the years and really thank them for their volunteer service in support of the exchange and the residents of Connecticut. So next, Marcin, if you'll go to the next slide. Oh,
There's no public comment. There's
sorry.
no public comment. Okay.
Okay. Sorry, yep, and I think I turn it back to Grant for a few slides here. Sorry about that.
Yeah, if I could I hear a motion from some member to adopt the minutes from last May's meeting? Hopefully from someone who was there.
Moved by Ted.
Thank you, Ted. Is there a second?
Second, this is two.
Two, thank you. Okay. Are there any comments, changes, edits to the minutes? If not, could we have a roll call vote, Marcin?
Graham Blader.
Yes.
Tito, Theodore Doolittle.
Aye.
Mark Schaefer.
Aye.
Matthew Brockman, and Minister Tutani. Thank you.
Thank you. I'll turn it back over to Susan now to talk about the vision, mission, and values of the committee or of the whole.
Thank you, Grant. We'd like to just take a few minutes to just touch on the mission and vision. So just as a reminder for people, in 2021, Access Health Connecticut began a review of the mission, vision, and guiding principles for the exchange, as those had all been adopted originally in 2012, excuse me, when the exchange was first getting off the ground, to ensure that these statements moving forward reflect the current and future state of the organization and its work. And in 2022, the board adopted a revised mission and vision statements that were recommended by the strategy committee. Work is continuing on revisions to the guiding principles. So for today, we just wanted to review that the new mission statement for Access Health Connecticut is to decrease the number of uninsured residents, improve the quality of healthcare, and reduce health disparities through an innovative and competitive marketplace that empowers consumers to choose the health coverage that gives them the best value. And then also the new the new vision statement for Access Health Connecticut is to provide Connecticut residents with access to the most equitable, simple, and affordable health insurance products to foster healthier communities. And if you go to the next slide, Marcin, we just have a graphic, thank you, on our values in action. And these are values that have been adopted by the staff, and they are always guiding us in our work serving the residents of the state of Connecticut. And then I just wanted to mention that I'm going to turn it over to Kelly Cody in a second to start our discussion. And we're going to start the discussion with what is on the agenda as item K, which is the 2024 plan year timeline. And we felt it was important to start the discussion with this, as there are some important date changes that impact this committee's work for the 2024 plan year. And we wanted to make everybody aware of those right away. So I will say thank you and turn it over to Kelly Cody, Carrier Product Manager now.
Thank you, Susan, and good afternoon and Happy New Year to everyone. As Susan mentioned, we're going to review some important timing changes for plan year 2024 that have impact to this committee, to the certification process, and to the issuers that are participating on and off exchange. The Connecticut Insurance Company, or the CID, has changed the rate and form filing deadline, and it's now due June 1st, 2023. Therefore, this committee will need to expedite the recommendation process so that the 2024 standard plan design recommendations can be presented to the board of directors for vote during a special March meeting. Once those approvals are provided by the board, Access Health will then accelerate the release of the issuer solicitation and then the application in support of the earlier rate and form filing date. This will ensure that our issuers are given a sufficient amount of time to determine the impact of the Access Health requirements and prepare them and prepare and submit their rate and form filings to the CID on time. Marcin, if you could forward to the next slide. This slide demonstrates for 2024 plan year some of the requirements. So the first box on the top left corner identifies that HHS has released the draft notice of benefit and payment parameters, which is a document we use to it provides guidance to the issuers on some of the changes that may be coming down the pike. If you look at the box below it, CMS also released the draft actuarial value calculator, also known as the AVC. Both of those documents were released in mid-December. a little bit earlier than they've done in the past. I think last year we may have received those documents and the calculator probably late December. So obviously that's really the kickoff for this group. Those are some tools that are used, and Julie from Wakely will be going over those details further on in this presentation. So the rest of the dates on here, one has been set obviously today. The next box on the top row is this meeting. But there's a couple TBDs that you're going to notice on here. One is obviously the final BPP and the final release of the ABC. So that's not anything out of the norm. Those are usually items that we are waiting for from CMS. So as soon as we're given maybe a heads up as far as when to expect those, we will certainly communicate that. But at this point in time, we do not have that information. So further on down the line, this is just outlining for you what are some of the next steps. So March 2023 is when, as I mentioned earlier, we would like to, if possible, present to the board any of the suggested changes for or recommendations for plan year 2024. Immediately after that, we will release the solicitation. And then following the application, and then the very last stop is the QHP and SADP applications that are due to Access Health from the issuers, which we are looking for a June 1st date that coincides with the rate form filings. Next slide, please. I think many of you are probably very familiar with this slide. And so this outlines from a plan management, the plan management certification life cycle. So presently we are somewhere in between the two, the circle at the very top for regulations and guidance and developing the plan and certification requirements. So there has often been a need to modify our standard plan designs so that they continue to be compliant with federal actuarial value or meeting mental health parity requirements. And each year, this committee has very thoughtful discussions about potential cost sharing changes for the standardized plans. And our actuarial consultant and our carrier representatives in attendance today have been very instrumental in supporting those efforts to develop those options for consideration, which are then presented to the board to vote. So at that point in time, usually the work of this committee is generally considered complete for the year, unless federal guidance is later modified. So originally I had said everything is in draft form. So a lot of times, much of the work that we do is prior to the finalization of the NBPP or the AV. So because everything's in a proposed status, and the proposed standard plan designs are based on that, if that information has to change and our plan designs or decisions that are made are no longer compliant with that guidance, we're asking that the committee, like they've done in years past, come up with a contingency plan so that this group doesn't need to come back together and we can present to the board either plan A or plan B, depending on how the final information comes to us. And especially with the expedited timeline, we're really suggesting that process continue for 2024. So I'm going to stop there for a minute and ask if anybody has any questions with regards to what I've delivered to this point. Okay, I think silence is good. So Martian, if you could advance. Thank you. So again, I think many of you are very familiar with this slide. This is really just for informational purposes. For 2023, this is outlining by the carriers which plans they had filed for on exchange. for 2023. And it also outlines what the requirements are for our standard plans and non-standard plans. I'm not going to go into detail because many of you are very familiar with this information. Just one thing to note that is that I know we had a lot of conversations last year about limiting plans or how many plan offerings there should be. So I just wanted to note that each carrier can offer up to 13 plans, and note that not one of the carriers have met that total requirement, or I shouldn't say not that they didn't meet the requirement, but they're offering less than the total amount that they can. So I think we're at a healthy amount on the exchange. I know there was a lot of conversation about if there were too many or not. Next slide, please. This is the individual market landscape. So this exhibit is displaying to you on and off exchange plans that have been filed with the SID. Obviously, the blue brackets outline the on exchange. The top box highlights for you by metal level and by carrier how many plans have been filed, and the bottom box includes the by product type. So you'll notice that if you're looking at just the on exchange, we have 10 bronze plans, which seem to be more. There's more of those obviously than the other plans, but if you consider that Access Health has the requirement that you must offer 2 bronze plans and 1 being HSA compliant. And then other noticeable from a product type standpoint, POS seems to be the more popular plan filed. Next slide, please. This is our 2023 plan mix for standalone dental plans. So this is similar to the medical exhibit. The dental, it's identifying the number of plans that are permitted per issuer. And then to the right, it outlines how many plans by carrier are offered. So, and last year, CICI entered the market offering a dental plan. Also, there was one thing that I wanted to mention about this. Last year, I had presented in an HBBQ meeting some changes that we were looking to make with regards to our platform, and that was integrating the dental onto the individual medical platform. So for 2023 open enrollment, Access Health was successful in integrating those two together, completely changing how a consumer would shop for individual products through Access Health. So instead of having to go in and enroll on the medical platform and then go to another place to enroll for dental, it's one-stop shopping. They go in, they see their medical plans, they select it, and then they can immediately following elect their dental plans if that was what they were looking for. So while I don't have actual enrollment numbers for 2023, it has been said that the enrollment has been quite significant this year, which could be contributed to the platform integration. So definitely a success on Access Health Point, combining those two onto one platform. So I just wanted to put that in there. Next slide, please. So certification requirements. I think, again, this is a repeated document. This is a listing of all certification requirement topics that have been discussed by this committee in past years. The state of Connecticut did not request any changes to the essential health benefit benchmark plan for 2024. And those would have had to have been submitted by the Department of Health and Human Services last year. I believe the date on the screen is May 6, 2022. So for 2023, this committee's review of certification requirements was really focused on just the standard plan designs for the individual market, and Access Health continued to not require standardized plans for the shop market. So for 2024, we are recommending that the committee review the standard plan designs for the individual medical and standalone dental plans, similar to last year. Any questions on that? Okay, great. Well, Julie Andrews of Wakely Consulting will now walk us through her presentation, which will include the results of the 2023 plans using the draft 2024 actuarial value calculator. Once she concludes her presentation, I will then go over with you CMS's annual review of the cost sharing limitations for the standalone dental plans. Julie?
Thank you, Kelly. Yes, hello everyone, Happy New Year. This slide just shows the agenda that we're going to cover for the 2024 rule changes and preliminary actuarial value results. And if you advance the slide, Martin, you know, in order to establish the standard plan design, there's several elements that we need, and you can see from the illustration that 3 of the 4 puzzle pieces have gray check marks, meaning that the elements are not yet finalized, and 1 element we have not fully received. So as Kelly mentioned, we still have a draft federal regulation, a draft federal AV actuarial value calculator. We do not have the final 2024 IRS HSA rules for the deductible and out of pocket, and we were not able to collect fully the issuer's individual analysis of the actuarial value calculations and mental health parity testing for each of the plan designs. But if we go ahead and go on, we can just talk about some of the things that are changing or what's been proposed in the 2024 regulation in the notice of benefit payment parameters. This regulation holds some key components, most importantly, the maximum out of pocket that's proposed for the 2024 plan year. And they are proposing to increase it to $9,450 from $9,100 in 2023, with some additional increases to the cost sharing reduction maximum out of pocket payment parameters. We will not have the IRS HDHP or high deductible health plan minimum deductibles and maximum out of pocket. Probably for 2024, as usually those are released in May. So we are using the 2023 minimum deductible and maximum out of pocket as guidance. There are also several state regulations that we need to comply with or consider in the plan development. There are 2 programs that will impact plan designs for 2024, but will not be a direct component of our standard plan design actuarial value work. The first is the Covered Connecticut program, which was established in 2022 and will be continuing under the recently approved waiver through 2027. So this program provides additional cost sharing protections for those who are ineligible for Medicaid due to their income falling between 138% and 175% of the federal poverty level. And then new for 2024 is a new program called the Connecticut Health Enhancement Program that encourages issuers to develop incentives, not cost sharing driven incentives to utilize preventive services. The federal AV calculator is the tool that CMS provides for us to identify and ensure compliance with metal levels. This determines the actuarial value of the plan, with the actuarial value meaning the percentage of cost sharing to be paid by the issuer for a specific plan. This year, there's several changes that are occurring. One thing that is not changing is they are not changing the base data. The base data is going to stay at 2018 data, but they are trending in an additional year to take us from 2023 to 2024. Medical trends are running from 3 to 6% from the years from 28 to 20 2024, and pharmacy trends are higher at 4 to 9%. There are some new programmatic changes or coding changes underlying the new tool. They've changed the copay calculation, and each of these changes are just to better align the tool's methodology with the way claims are actually adjudicated in the marketplace and how issuers handle cost sharing. So with the new copay calculation, copays will no longer count towards the deductible. They will just continue, though, to accrue to the maximum out of pocket. This is the way normally plans handle copays, and it creates a small decrease or adjustment downward in the actuarial value results. They've also incorporated an algorithmic update to more accurately calculate spending during the deductible phase for plans with separate deductibles, medical and pharmacy, but a combined maximum out of pocket, as well as some adjustments with situations where the deductible does not apply to a lot of services, and there's the possibility where someone may actually hit the maximum out of pocket while not satisfying the deductible. And so the combination of these changes and the trends is, we're seeing a lot of variation by plan design, but generally mostly seeing an increase in the actuarial values, which will impact what we need to do with the plan designs for 2024. So on the next slide, there are some additional statutory changes that we need to follow when defining the cost sharing for standard plans. At this time, we're not unaware of any active legislation for the 2024 session that may impact the plan design process. But myself and the actuarial health CT team will continue to monitor what is happening legislatively and tracking to see how it may impact plan designs. So on the next slide is our preliminary results. I have on here two tables. The top table provides the actuarial value for the plans. The top first row are the actuarial value ranges for 2024. These are proposed. They are not changing from 2023's ranges. If you will recall, in 2023, CMS did narrow the ranges at the lower end, increasing the minimums. The second row are the final actuarial values under the 2023 calculator. And then the third row represents the 2023 plans run through the 2024 calculator without modifications, and just showing the net change based on my calculations or Wakely's results of running that process through. At this time, as I mentioned, we do not have fully all of the issuers' evaluations back. Otherwise, I would be presenting those here. You can see those that are in the red font based on the results we did have heard back from issuers, and based on my estimates, these are the plans that we will need to make modifications to because they will fall outside of the actuarial value ranges for 2024. The bottom table represents the cost sharing reduction variations for the standard silver plan. And so based on the results to date, this could change when we see all of the plans, all of the issuers' results. Right now, only the silver standard plan and the 87% CSR variation may not need modifications. So if we go to the next slide, so historically, in 2022, we made a big push to make sure to try to get as many plans to have the lab services not subject to deductible. In 2022, we also had to incorporate the new diabetic cost sharing for drugs and other care items. In 2023, we incorporated the new legislation covering breast and ovarian cancer screening. Generally, what historically, for those who may be new to the committee, we've tried to make as small amount of changes or steps that would impact consumers as possible, focusing generally on the maximum out of pocket and then touching the deductible where necessary. Other considerations that may come into play will be, again, additional potential legislative requirements. And if there's some sort of changes that may offset likely premium increases in the coming year. So if we go ahead, we can just kind of do a review of the plans. These are just some plan services or cost sharing that are unique to the plans, but because of their impact on the actuarial value, they are not specific inputs into the actuarial value calculator, but they do have their own unique cost sharing, which you can see in the appendices. Just some additional notes and caveats in the next slide. As far as the services that I'm going to be showing are for in-network only. There are out-of-network services, but those are not incorporated into the actuarial value. And then generally we are showing, unless specified, the individual level deductibles, maximum out of pockets, but family limits are 2 times unless specified. And then preventive services are all covered without cost sharing to consumers. So the first thing that we can go on to is the gold plan. And as I noted from the summary, is that this one is likely, let me just, that we will need to make modifications to this plan for the coming year. I don't have the exact amounts, but with the maximum out of pocket being at 6,000, it seems a natural step to potentially see what impact we would have to make to the maximum out of pocket to bring the plan into compliance. I don't know if anybody has any other thoughts on the gold plan as far as other levers or mechanisms that could be changed. For the next steps is once I get the results from all of the issuers, then Wakely will make some evaluations and based on your feedback here today, go back to the plans with suggested changes that can be tested and then can be presented at our next meeting.
This is Mark. I have a question about the adjustments available, and this may not be responsive to the question you're raising, but you mentioned that this year they're introducing a health enhancement plan option or feature. I know the state employee plan had favorable cost sharing, more favorable cost sharing, and a reduced premium expense because of the actuarially established reductions in avoidable utilization as a result of participating in the various HEP sort of elements.
Mm-hmm.
And so I noted that with HEP, it doesn't necessarily, with the HEP and in these plans, it doesn't necessarily involve any sort of modification to cost share or financial incentives. And I'm just wondering why such a light touch on HEP and whether there's a way to implement HEP in a more significant way that would have the same cost sharing and overall premium benefits that it has had for state employees.
So you're referencing, is there a way to, because my understanding of the regulation is that it's not necessarily cost sharing driven, but it's incentives outside of the plan design. There is the opportunity, and this committee has looked at value-based plan designs, trying to do similarly what has been done at the state level. There's just particular challenges with doing those variations. I think that the most recent diabetic legislation was one of those pieces, is to, ensure compliance through lowering the cost sharing for diabetic care elements. I'm open to the committee if there is a certain value-based care program that to be considered, or if you have thoughts on that, Mark.
My only thought at the moment, because I was unaware that any step had been taken toward HEP in the context of the exchange, is that I would much appreciate a more rigorous examination of what it would take to implement a closer approximation of the state employee approach, and what those challenges are, since it seems to me it's a way to achieve the mission and vision as articulated, which is healthier people, and a value-based plan helps do that by virtue of its focus in part on preventive care, but also chronic care management. And if it lowers overall, and it would seem to me that it could, I know you can't adjust premiums, but it might be possible to adjust out-of-pocket, maximum out-of-pocket, for example, based on participation, because there is going to be, an actuarial value or healthcare cost impact for the patients who are participating.
Mm-hmm. It's been a while since I've looked at the state plan. I know that they had a focus on diabetes. Is there another?
They had things like colonoscopy screening, breast mammography, and other preventive care activities, maybe getting your lipids checked. I only recently rejoined the state employee plan and haven't re-looked at it, but I had approached the exchange back when I was at OHS, I think 5 years ago, about this with Tom Woodruff and some others, and it was I understood the constraints around the requirements around actuarial around AVC made it very difficult to thread the needle. And there wasn't a will to do so at the time at Access Health Connecticut. And I think that, we're now 5 years out from there. The value-based plan design has been incorporated into Medicare Advantage. There's more experience with it, and it would be, in my view, at least, of interest to take a look at the latest versions of the HEP plan at the state employee, and to revisit what the challenges would be to a more meaningful integration of those approaches in this context.
Hi, Mark, this is Susan Richby at Access Health. We did, and I think it was before you joined this committee, but the committee was interested in, VBID, this particular committee, a few years ago, and we did pull together a great deal of research on it. And it is, it is something exchanges have looked at, but because of the ACA guardrails and AV and mental health parity, it's more challenging to implement than for a self-funded plan like the state employee health plan. But we can pull together some of that information and look, for anything we can update, to give the committee some information at our next meeting. And I think Paul Lombardo is on today too. For what Julie was referring to, the HEP for 2024, comes out of state legislation. And I think it's primarily geared towards incentives for, members to take advantage of the preventative screenings, not so much at, cost sharing, but in other incentives that the carriers could come up with. But we can certainly, pull some information for the committee on VBID. And I know there's been a group that's worked with, I think, Oliver Wyman a few years ago about this. And it's just a little challenging, to implement in the same way that it's done in the state employee plan, which has the, stick, if you will, of higher premiums if people don't comply with the preventative requirements versus, what I think can be done in these types of plans.
I see some people have some hands up. Ted, do you want to go ahead?
Yeah, thank you. Per Mark's comments, certainly not no objection to getting more information. However, as we gather that information, I think we need to look beyond just the state health plan HEP program. There's a lot of scholarship on these wellness programs, and a lot of it is not super optimistic about impact on healthcare spending. So if we're gathering the information, let's make sure we gather some of the evidence out there beyond just the state health plan.
And someone else has their hand raised.
Yeah. Hi, Julie. Thank you. It's Paul Lombardo from the Insurance Department. Mark, I just want to also identify, and I'm not sure I heard it in your describing the HEP program with the state, but there's also penalties, and I think Julie just mentioned that there's penalties for not complying with the preventive service criteria within the state plan. And that is one thing that we cannot do with the individual and small group market ACA. And there's actually some discussion at the federal level because our state plan is a self-funded plan as well. Whether self-funded plans can introduce disincentives for not complying with preventive services and the criteria set up for preventive services. So that HEP in the statute was really meant directly related to not enough people are going and getting preventive services in the fully insured market. Now, to Ted's point, I think there's been some general information out there that says that folks that regularly see their PCP and regularly get preventive care, there is some level of savings. What that savings is, I think Ted's right. We need to make sure that we understand exactly what that savings or estimated savings is. But I think that was the intent of the HEP being implemented in the fully insured market in Connecticut from that perspective, is to just have people go get checkups, get regular eye exams, dental exams, so forth and so
on. Thanks, Paul. Much appreciated.
Okay, well, so what we can do is, as Susan mentioned, is pull some of that additional information back together for the group for discussion in the short term as well. Unless others have thoughts, we'll work on taking kind of a plain vanilla approach at least, and look at, can we just modify the out of pocket to bring this plan in compliance with the issuers, unless someone else, has a strong feeling with regard to any of the co-pays or other cost sharing elements presented here.
Julie, could you just remind us, what did we do between 2022 and 2023? Was it strictly a change in the out of pocket, or do we also play around with the deductible?
For the most part, we focused on the maximum out of pocket. Last year, I believe it was the silver plan where we did end up doing some adjustments to the deductible, just because those plans, Marcin, if you want to advance the slide for the silver plans, those plans are already almost at the maximum out of pocket, which last year was 9,100. Oh, go ahead.
Julie, before you move on, I just want to kind of close the loop on the preventative measures. Mark, one of the strategies that we are exploring now is a communication approach to very aggressively encourage all of our members. First of all, make sure they have a primary care provider, and also strongly encourage them to make sure that they at least see the doctor at least once a year. See, this is going to take some education and some communication strategies, but my team and I are exploring how do we get people to take action on their own behalf, above and beyond what we've just discussed. But more to come on that. But again, that's outside of these plans. This is more about how do we get our members to really become more engaged in their own health, and by working with them, communicating with them directly. More to come on that. Okay.
Thank you for that. I appreciate that. What do you have any statistics on the percent of members who in a given year see a PCP?
No, we don't have that. That data is claims information that the carriers have that we just simply don't have access to. But again, the part of our strategy is to do surveys to the extent that we can, just to get that to get the baseline for that information. But about going forward, this will be more about how do we to ensure that all of our customers at the very least have a PCP, number one, and number two, are seeing their PCP at least once a year and following in the any prescribed health approach to manage their health.
So we don't have aggregate performance data on the claims-based performance data.
Paul, I don't know if you feel comfortable talking about that, but I'm not aware of not Access Health.
Well, I'm just thinking that I was involved in the setup of the APCD when I was at OHS, and also the production of the quality measures scorecard, the first effort to do that. And that was based on an attribution methodology that identified who had a primary care provider based on a certain definition established in the Quality Council. And since the individual plan data, the exchange plan data is in the APCD, it would seem to me that it would be possible to run an interesting array of reports restricting the member set to participants in the individual plans. At least as a starting point, it would be interesting to look at to see what's out there in terms of plan performance and things like what you said, which is if you ran a plurality, if you ran an attribution model on membership, how many would have visited a practitioner who was identified as a PCP in a year or 2 year look back?
And I think, I don't have access to APC data. Oh, I'm sorry, Ted, go ahead. You have a question.
Yeah, well, just a comment that actually Mark's comments kind of superseded it, but just to underline, this is exactly the kind of thing, maybe the APCD, the all-payer claims database at this point is mature enough for us to be able to ask OHS these questions and get good information. That's the point I was which Mark was making also. I'm just reinforcing that. Thanks, Julie.
Mm-hmm. Yeah, I think, go ahead, Matthew.
No, sorry, I'm chewing a sandwich. That's why I had my camera up. But just to that point, I actually 100%, and I actually, because we had in one of our board meetings a similar question around are there ways that we can encourage more of our folks who buy product on the exchange to go to their primary care? And so I actually had started a conversation with some of the folks over at the APCD about getting that data. So it's something we should talk further about, more broadly, but yeah.
Yep. Yeah. And I have not worked with the APCD data, though I've seen other states. Yeah. And I think, that analysis and everything would be valuable, and maybe something that may need to be considered for 2025, just given the June 1st deadline and the plans,
Yeah, I'm not advocating for anything for this cycle. I appreciate the time, the lead times that are required. I would say that the APCD's data is available to extract on a de-identified basis on request. So you could even get the data going back 5 years and run some analyses yourself.
Okay. Yeah, and I think it would be interesting. And I think too, you know, with the pandemic and people being, you know, departed or separated from maybe their primary care physician, as well as all of the new people that are enrolling, you know, with the enhanced subsidies associated with the American Rescue Plan Act, as well as the Inflation Reduction Act. You know, there may be some individuals that still haven't gotten connected with a primary care physician. So it would be interesting to see how that has changed and how to, as James mentioned, ensure people get connected and begin, you know, getting back to a regular care provider model. But, you know, we can definitely, you know, get some of the information and maybe kick off something that may be a longer term project or discussion that may be just out of sight of what is needed for 2024.
So,
thanks so much.
Hi, this is James. We will follow up with OHS to see where they are with the data, and again, and report back to this committee either before this committee closes its 2024 planning, or if it's after that, we'll send this committee a report to emphasize where we are.
Okay. So Marcin has the silver plans up along with the cost sharing reduction plans. And Grant, as you mentioned, last year we adjusted the maximum out of pockets as well as the deductibles on the silver plans in order to bring them into compliance. Let's see, I think the standard silver, the 73% and 87% are at the 2023 maximum out of pocket limits. We could potentially, you know, increase them to the new proposed limits, but likely we will need to also potentially adjust the deductible or some other cost sharing element that is shown. I don't know if anybody has any thoughts. I know that most committee members would prefer not to make any particular service category subject to the deductible if that can be avoided. I believe that's still a true statement, or if anyone has any new thoughts on that as they look at the high level plan designs.
Hopefully not.
Yeah.
And just to add, this is something that we've been, you know, trying to communicate. I know I've talked to the board about it recently. Really making sure that people understand the value of our plans, and especially obviously the silver plan probably is where we see it the most, the first dollar coverage, and having the services in nearly all, I think, but the HSA plan, you know, that people use the most, going to the doctor, mental health visits, labs, as we've done over the last few years, tier 1 generic drugs, making those much more accessible to people and having them not be subject to the deductible. So that's been an important focus. And the silver plans have a separate low deductible for prescription drugs as well for those other tiers, which does help too.
Right. Thanks, Susan. So we have about 5 minutes left. I guess, you know, just based on the initial results, we are also going to need to make modifications, if you advance the slide, Marcin, to the non-HSA bronze plan. We have room, you know, to increase the maximum out of pocket and deductible as necessary. Most of the other services are already after the deductible. We'll also need to make adjustments to the HSA plan, which is on the next slide. And right now, I think we are at the maximum. Let's see. Where's the IRS? We have room because we are within the IRS maximum out-of-pocket limit for 2023, so we have some room to move there as well. So I guess as my takeaway, I will work with the plans to come up with some options that will comply with the 2024 AV calculator for the next presentation. And I will go ahead and turn this back over to the Access Health team.
Kelly.
Kelly.
Yes.
Yeah.
So, as promised, I was going to go over the CMS annual limitation on cost sharing for the standalone dental plans. So every year, CMS reevaluates using data from the previous year to identify whether or not adjustments need to be made, excuse me, to the cost sharing amounts for children, or one child versus two or more children that are covered under the dental plan. Now, let me just remind you that this cost sharing amount is only for children. It does not affect the adult coverage. It is only for in-network benefits only. So for the 2024 plan year, CMS has calculated that those values can be increased to $400 per child, $800 for two or more covered children. In 2023, this group opted to leave the annual limitations as is at the $350, $700. And I believe that the last time that this amount had been adjusted by this committee was in plan year 2016. So this is something that we will need to ask the group to weigh in on and decide if they would like to leave the amounts as is or to increase it to the amounts that are available per CMS's guidelines. Next slide. So finally, to wrap up, these are our proposed agendas for our future meetings. So obviously January 10th is today. We have 3 meetings scheduled. The February 27th meeting was originally scheduled as tentative. So based on our expedited year, depending on how we get through our conversations and how we advance, we may need to have that February 27th meeting, but this is just the potential agendas and obviously could shift based on the need or how quickly or not we get through certain topics. So with that said, I believe that is the end of our presentation. And next steps.
So I think for the next steps, we have the information that the group discussed, that we'll work with Wakely and pull some information for you that on, Vivid and HEP and that discussion for the next meeting. And also to the James's point, working with OHS about getting some APCD data to look at utilization.
Okay. Is there anything else that needs to be discussed? If not,
I
could we
just
have a
wanted
vote
to
to-
mention, I'm
Yeah,
sorry.
go ahead.
I just
Yeah.
wanted to mention really quickly in the appendix there's a whole host of additional information in there. We don't typically go over it in the meeting, but just as an FYI to those on the call or who may be new to the group, there's plenty of additional documentation for your reading pleasures.
Okay. Thank you. Could I have a motion to adjourn from a board member?
Chad Doolittle, motion to adjourn.
Thank you. Second?
Seconded, Mark Schaefer.
Mark? All right. Mark, could we have a roll call vote?
Sure. Craig Ritter,
Yes.
Theodore Doolittle,
Aye.
Mark Schaefer,
Aye.
Matthew Brockman,
Aye.
Jun Goen,
Aye.
Ellen Skinner, and Manish Dutani. Thank you.
Thank you, everyone. We are adjourned. See you in a couple of weeks.
Thank you. Bye-bye.
Thank
Bye
you
now.
all. Bye-bye.
Thank you.
Bye, everybody.